everyone, and welcome. Today, we're going to build a solid clinical framework for a condition you're going to see all the time, IgA nephropathy. It's the most common primary glomerular disease in the world, so knowing how to approach it is, well, it's absolutely non-negotiable. Okay, let's just dive right into a classic case. Picture this. You've got a 40-year-old patient, just got the biopsy results back. It's IgN. They have significant proteinuria, 1.5 grams a day, and persistent hematuria. So what's your plan? What's your framework? By the end of this, you're going to have a really clear step-by-step way to answer that exact question. So first things first, let's talk about the challenge here. IgN is often kind of sneaky. The progression can be super slow, maybe just a 1 to 3 milliliter per minute drop in GFR each year. But you absolutely cannot let that fool you. This is not a benign condition. That slow drip can eventually turn into a waterfall. And this is exactly why we can't afford to be complacent. For patients with that higher level of proteinuria, this number, 20 to 30%, that's their risk of ending up on dialysis within 2 decades. It's a really sobering statistic, and it's what makes our management so important. Okay, so this brings us to what is probably the most critical first step you're going to take right after the diagnosis is made, figuring out your patient's risk of progression. Seriously, this one step dictates your entire management plan. It tells you who you can manage with supportive care and who needs more aggressive therapy right out of the gate. Your risk assessment is basically built on these 5 pillars you see here. We're looking at proteinuria, which really tells us how much glomerular damage is happening. Then hypertension, a huge driver of progression. Their baseline GFR, our starting point. Persistent hematuria, which is a sign of ongoing inflammation. And finally, the biopsy itself, which gives us the ground truth with that Oxford MEST C-score. Now, here's the thing. Of all those factors, proteinuria is king. This number, greater than 1 gram per day, that's your big red flag. It's the key threshold that tells you a patient is at higher risk. But, and this is important, while greater than 1 is the risk marker, our ultimate goal of therapy is to crush that proteinuria down to less than half a gram per day. So how do we pinpoint that very high-risk patient who needs us to act right now? Well, this table is your cheat sheet. We're looking for that persistent proteinuria over a gram, moderate hematuria that just won't go away, an eGFR already under 60 or dropping fast, and those active lesions on the biopsy. If your patient is ticking 3 or more of these boxes, they are officially very high risk. For them, you are not waiting around. You are starting immunosuppression right alongside supportive care from day 1. So what's our actual treatment playbook? Well, it's really built on 2 core strategies. And you can just think of it like a pyramid. The big, wide, strong foundation is supportive care, and that's for every single patient. And then the very top of the pyramid is immunosuppression, which we save only for those at the highest risk. And this slide just lays it out perfectly. Pillar 1, that foundational supportive care, it is absolutely non-negotiable. Every patient, no exceptions, should be on an optimized RAS blockade with an ACE inhibitor or an ARB, have really tight blood pressure control, and get counseling on lifestyle. Only after that's all in place for those very high-risk folks we just talked about do we add Pillar 2, immunosuppression. Okay, so you've made the call to immunosuppress. What's your first move? This table breaks it down. Systemic glucocorticoids are still our preferred initial therapy. And why is that? Well, because a major trial, the testing trial, showed they are the only therapy proven to reduce the hard endpoint we really care about, progression to end-stage kidney disease. Now, of course, this means you need pneumocystis prophylaxis and careful monitoring. Alternatives like targeted-release budesonide or MMF are great at lowering proteinuria, but they just don't have that crucial outcome data, at least not yet. And please, always remember, MMF is teratogenic. That's a critical counseling point. All right, you've started therapy, but your job is definitely not done. Managing IgAN is a dynamic process. It's not a one-and-done decision. So that brings us to the follow-up strategy. This is all about monitoring how your patient responds and being ready to adjust the plan. So fast forward 3 or 4 months, your patient's back in clinic. You're going to be asking yourself this exact question, and their response is what determines your very next move. So let's just quickly walk through the 3 possible scenarios. Let's start with the best-case scenario, a favorable response. This is the goal. Your patient's proteinuria has dropped below that 1 gram per day threshold, and their eGFR is holding steady. This is a huge win. Your action here is pretty straightforward. You're going to start a slow taper of the glucocorticoids, with the goal of being completely off them over the next 6 months. Okay, next up, the partial response. This is kind of the gray area. The proteinuria is down by at least 50%, which is great, a big improvement, but it's still hanging out at or above 1 gram per day. So here, you're still going to complete the glucocorticoid taper as you planned. But if they also have that persistent moderate hematuria, this is when you start to consider adding a second agent like MMF. And finally, the toughest scenario, no response. The proteinuria has barely budged, or even worse, their kidney function is actually declining. This is when you have to escalate therapy. The first step is to add MMF. If the patient is still not responding after 6 months of that combination therapy, that's when you start considering the newer agents, like the recently approved complement inhibitor, iptacopan. So, to put it all together, here's a really simple, practical monitoring schedule you can use. In those first 3 months of therapy, you're seeing them frequently. That 3 to 6 month window, that's your key decision point to modify treatment. And then, once they're stable, you can stretch out the follow-up. Now, this framework covers most patients, but what about the outliers and what's on the horizon? So let's quickly tackle the most urgent variant of IgA nephropathy, and then we'll look ahead to what is a really exciting future for therapy. Okay, IgAN with RPGN is a true nephrology emergency. This is defined by a catastrophic drop in eGFR. We're talking over 50% in 3 months or less, with a biopsy showing extensive crescents. When you see this, you have to act immediately. The treatment is aggressive. It mirrors what we do for ANCA vasculitis with high-dose glucocorticoids and cyclophosphamide. This is a save-the-kidney-now situation. And now for the really exciting part, the future. The whole treatment landscape for IgN is about to be completely transformed. There's a wave of new drugs that target the core pathophysiology, and they're in late-stage trials right now. We're talking about APRIL and BAFF inhibitors like sibeprenlimab, more complement inhibitors, even anti-plasma cell therapies. This is a total game changer. This quote really just gets to the heart of our current approach. It says it all. We don't have a cure for IgAN yet. So our job as clinicians is to be absolutely relentless in slowing down its progression. We have to use every tool in our arsenal, from supportive care to immunosuppression, to preserve every last bit of kidney function for as long as we possibly can. And all this brings us to our final forward-looking question. With all these new targeted therapies becoming a reality, therapies that are potentially safer and more effective, how is our definition of high risk going to have to evolve? Are we going to start intervening earlier at lower levels of proteinuria to prevent damage before it even starts? It's a really interesting question, and it's one we're all going to be answering together in the very near future.